The topic of my lecture is about the road to becoming a surgeon. And we'll go straight perhaps from where you guys are currently just now to where I'm sitting in my office just now at work, having just finished a long day's clinic. Hopefully we can encourage some people to take an interest in a similar career path. So the objectives of this lecture, I always find people interesting. So with that in mind, I'll tell you a bit about myself and my background and the training that we've had and the work that we do. I also talk in broad terms about the career pathway through both medical school and also postgraduate career. And I've got ample time reserved for all of you at the end, as Ashley was saying, for a question and answer session. And I would welcome questions to enlighten any of you about anything that you'd like that's pertaining to the topic. So I'm a consultant trauma and orthopedic surgeon. I'll go into a bit more details about the specifics of what that involves. This is me with my team in the operating theatre. Now, I specialise in reconstructive knee surgery. So that includes people who've had sports injuries, who you might have heard on TV, who have cruciate ligament injuries and such like. So we do ligament reconstruction, and also people who in their later years of life developing arthritis in their knee, who need knee replacements and everything in between. So it's a very satisfying job. I absolutely love my job. We have the privilege of helping a lot of people get better. People present with pain and disability. We provide them with treatment to help get them back onto the road to recovery to enjoy their day-to-day activities again. But a key thing here from the photograph, our job, certainly as a surgeon, is all about teamwork. I can only do my team because of the fantastic team that I have around me, and collectively we offer a very good service. That's a recurrent theme throughout many facets of the NHS. I am a clinical academic, so as well as my clinical work as a consultant trauma and orthopedic surgeon, which I'll go into further details a bit later on about my day-to-day work. I also have a significant proportion of my work with academia. Now, I'm an honorary clinical senior lecturer at the Newcastle University, specifically the Faculty of Medical Sciences and the Translational and Clinical Research Institute. I have the privilege of doing both teaching medical students, lecturing them, examining them, and also have the privilege of supervising people doing research at the university. And research is very important as well. There are people in their undergraduate and postgraduate career who take part in this, and it's important. And we'll talk about the importance and relevance of research too. So as a clinical academic, I've got effectively two very busy full-time jobs, but it's very satisfying. So as well as helping patients, I also help the next generation of doctors progress in their career and help them with their training. I have many hats, as it were. I'm also very privileged as a very experienced knee surgeon that I sit on the executive board of the British Knee Society. All facets of surgery have overarching bodies, and within the British Knee Society itself, we organise annual forums and conferences, which our delegates, other consultants, doctors in training, and even medical students attend to get lectures from eminent surgeons who share with them the very latest innovations in their field. And we also take part in helping to promote and deliver research, education, and we also help devise national guidelines which change over the course of time to keep up with the changing face of medicine and the recent research innovations therein. And I'm at the back row, third from the right, and these are with my fantastic colleagues who are eminent professors and senior clinical academic knee surgeons like me from up and down the country, including great units like Oxford, Cambridge, London, Manchester, etc. So it's also a great way to share, exchange ideas with other very good experienced knee surgeons too, and it helps us to help other surgeons improve their day-to-day practice too. Furthermore, I'm also the editor-in-chief of The Knee Journal. The Knee Journal, as the name would imply, is a specialist journal which looks at all facets that are relevant to the knee joint. This looks at not just knee surgery, clinical research, it also looks at rehabilitation, basic science, anatomy, radiology, anything ever to do with the knee joint. Researchers from all over the world conduct the research and submit it into our journal. And I'm very privileged to also work alongside an international editorial board, where the associate editors I work with are very experienced clinical academics and professors of knee surgery, and that ranges from Denmark, Japan, America, Germany, Italy, Holland, as well as other parts of the UK. And this is a great way of critically appraising research. It means we're able to deliver evidence-based medicine. We're very up to date in all the very recent research, and we evaluate and critically appraise papers and decide upon appropriate ones of high caliber to proceed to get peer-reviewed publications. And this is ways that people can share their new innovations and new advances in their field with the rest of the world, and then people who keep up to date, as we all do, with their day-to-day work, will read journals to look at the most recent publication. So I'm in a very privileged position to know about tomorrow's research today before it's even published. And I have, again, in keeping with the theme of teamwork, I have an amazing team that I have the privilege of working with. Now, Newcastle University is an excellent university, and of course I would say that. It's a Russell Group university. It ranks very highly on the world stage of universities in terms of its caliber, prestige, and its research and education output. It's also a fantastic city. It's a very young city. There's lots of things to do here for young people. It's got the living in Newcastle. You've got the pleasure of a big urban city. There are shopping centres, a very good football team, I might add, and as well as being close to the coastline and fantastic beaches. And there's also rural areas in Northumberland. So you have an amazing choice. It's a fantastic place to live for your 5 or 6 years that you'll be studying here. It's incredibly sociable. There's lots of nice bars and restaurants and lots of social amenities. So in terms of a place to call home during term time, Newcastle is an amazing city for its university, but also for its social amenities too. Now, your medical degree you graduate with is a Bachelor of Medicine and Bachelor of Surgery. In Newcastle, that's called MBBS. There are some universities which give you the word of MB, CHB. It's the same thing. I graduated in Scotland University, for example, in Dundee. We graduated with an MB, CHB. But you'll notice some slight variations depending which university you apply for your medical degree, some called MBBS and some called MBCHB. But they both mean the same thing. You graduate with a Bachelor of Medicine and a Bachelor of Surgery. Now, in Newcastle, it's MBBS course. It's a 5-year degree program. So in your UCAS code, that's A100. We do also have a 4-year accelerated program, but that's for people who've usually done another allied degree, a 3 or 4 year degree in biomedical science, or another degree that's considered appropriate. Again, I won't get into the minutiae of the admissions processes, as Ashley said, but Newcastle offers both a full-on 5-year degree as well as an accelerated program for people who are postgraduates looking to do medicine as a second degree. Now, for the 5-year program, years 1 and 2 are predominantly focused on, or more so, 1 and 2 are focused on the fundamentals of what medicine is. Things like anatomy, pathology, microbiology, histology, and they also introduce you to things like clinical skills examinations, ethics, professionalism, communication skills, as well as other sciences like the pharmacology and the foundation building blocks. So you get a good grounding of education to build on for your clinical years. And we also have, of course, at very early years, you'll get attachments with GPs and other clinical placements and you'll get taught some clinically relevant material even from year one that show you the clinical relevance of the basic sciences that you're being taught. And it gives you an excellent grounding for you to move on to the next phase of years 3 to 5. Now, in years 3 to 5, you're effectively placed in a hospital. You've got your clinical base units, and you get placed in groups across a variety of hospitals, which are all affiliated across the northeast of England with Newcastle University. And you go there, you're attached to specialities, and you get on the ward clinical experience, and that further builds on the previous year's academic training. So overall, it builds you to prepare for life as a FY1 doctor, and it prepares you very well indeed, because working with a lot of Newcastle graduates, the caliber of resident doctors, as they're called these days, the foundation doctors, they're excellent, and that's a testament to the great quality education and teaching that Newcastle University has, as well as obviously the very high caliber students that we attract. Now, one very interesting thing about Newcastle University specifically, all or most universities offer the option of doing an intercalation degree. Now, by that, I mean you do your 5-year, keeping with the full curriculum, the 5-year MBBS degree, but you can opt to do a 6th year, more focused on a research-based discipline. Now, in most universities, it's usually done between years 2 and 3, and that's a natural transition going from, say, the more preclinical years onto the more clinical years, and you're awarded a Bachelor of Science honours degree. In Newcastle University, you can actually also get put in with the final year biomedical sciences degree. In some universities, it's referred to as a BMed-Sci, which is a Bachelor of Medical Science, but they're all very much the same theme. One thing Newcastle University does very innovatively that other universities do not do is they give you the other option of intercalating between years 4 and 5. Because you've already completed 4 full years of university, doing the intercalation degree at that point actually offers you the opportunity to get a master's degree. Doing it between years 2 and 3, it's a bachelor's degree. Doing it between years 4 and 5, it becomes the award of a master's degree. And we have a very good, very well-established Masters of Research course. I have the great privilege of supervising intercalation MRes students who do a substantive piece of research, which involves semester 1 getting top modules on the topics of research, and then the other 2 semesters being attached to myself, physically conducting clinical research, basic science research, laboratory research, and data collection, and writing a dissertation, and then at the end having the dissertation examined along with a poster and oral presentation. And that gives an amazing foundation, and they get very well an excellent background in research. And a lot of them then spurs them on to go and do further research as a postgraduate doctor. The really good caliber students we have even generate publications in journals, as well as national and international presentations. So it's a really good, innovative opportunity here at Newcastle University. I will say one other thing as well. Most universities are 5-year degrees. There are some universities that are 6 years, and they include an intercalation degree as mandatory. In Newcastle University, it's an optional intercalation degree. So people who feel that they have a great interest in this, they opt to do it. But of course, for people who feel that that's not necessarily their forte, that's not mandated for them. But there are some universities where this it is a 6-year degree because they mandate an intercalation degree. Just something to think of when you come to apply. But for Newcastle, a Masters of Research, in addition to your MBBS degree, that you're onto a winner before you even started your day one as foundation doctors. That's why we generate excellent doctors at Newcastle University. Now, as well as the undergraduate curriculum, you also have a number of societies that are very active. They include the Academic Medicine Society, where students of all years have the opportunity to join the Academic Medicine Society, and they then get signposted for, I sometimes get invitations to give a lecture for the Academic Medicine Society to give them more insights into research. That allows them to network and get in contact with clinical academic consultants like me to do research alongside their medical degree. There's also the Surgical Society, where people who develop an interest in surgery early on in their medical degree, they allow them to buddy up with a consultant mentor. It allows them to go and attend surgeries, theatres, etc. So it allows a window of opportunity into life as a surgeon. So these are all, there's also the Orthopaedic Society, which, as the name suggests, people who are interested in orthopaedics, in the Sport and Exercise Medicine Societies. These are but a few of many societies where we have a very proactive student community who then take the onus and leadership on the role to develop these, make other students aware of them, and these are great ways of raising awareness of surgeons, specialities and societies. Within the actual MBBS teaching curriculum itself pertaining to surgery, you get an introduction to surgery even in the preclinical years. We have lectures in orthopedic surgery, even in year 2. We have a number of surgical related lectures early on, and they usually parallel the same field or topic that's being taught at the time, alongside the relevant anatomy, pharmacology, etc. So it's introduced in early years, and of course during your clinical placements in the later years of the medical curriculum, you get placed into surgical specialities, medical specialities, and community specialities as well, like general practice. So it gives a very broad exposure to all these areas. So you get clinical training in teaching surgery. Now, most universities, I believe, offer this student-selected components. Now, Newcastle University, at the end of your 4th year, you've had a lot of training of just about every speciality there is in medicine. And by the time you get to the end of your 4th year, you will have already have developed an interest to some degree of certain specialities. You then have 2 student-selected components, SSC periods, where you pick and go and work in a speciality of your choice full-time for 4 weeks, and you shadow the consultant, his resident doctors and his trainees and doctors, and you get an excellent exposure and insight into that particular field. So, for example, we have a very successful SSC program in trauma orthopedic surgery in my hospital. They come along with me to clinics, theatres, and ward rounds. They shadow and follow our resident doctors when they go to Clark patients in A&E, and this gives great exposure of clinical training, and this allows them to further cement their interest in particular fields, and that also helps inform decision making for which specialities they want to choose in the foundation year, which I'll come on to shortly. And another facet is the medical school elective, usually done in 5th year, again I believe offered by most medical schools. This again is where the student picks a field or even 2 fields of their choice. It's usually advocated to do anything between 6 to 8 weeks of a speciality, and you're not mandated to do it in the UK. So, for example, when I was in university, I and my friend in my year, we went to Spain to do our elective. I did general surgery and orthopedic surgery, and my friend, who was a bit more medicine orientated, did medicine in the same hospital I did, and we had a fantastic time, not just getting exposure to a different healthcare system altogether. We get to get further exposure in our own clinical areas of interest, and of course experiencing life in a country abroad for a full-on 8 weeks. So some students choose to stay in the UK, some students choose to go abroad. So the world is your oyster, and people, I still, even now, still remember fondly my medical school elective. So these are all exciting opportunities to further your interests in areas that you develop a particular interest in. So what is surgery? Now, many of you may watch programs on TV which are hospital related. Some are fly on the wall documentaries, some of them like Casualty or other American sitcoms which are set in the hospital workplace. Now, surgery itself has its definition set in as far back as Greek or Latin, and its literal definition is hand work. And that's because as a surgeon, most of the work that I do, particularly operating theatre, involves manual dexterity in doing surgery. I do, on occasions as well, have to use my head, as my physician colleagues will sometimes, we have some banter and joke where physicians do a lot more thinking than surgeons, but surgeons do a lot more doing than physicians. But yeah, the literal translation is handwork, because surgery is a very craft speciality. Now, there are many different surgical specialities. I'll give you a window into a few. Cardiothoracic surgery is an area which is specialized within heart and lung surgery. This can include things like mitral valve replacement, coronary artery bypass graft, pneumonectomies, as well as heart and lung transplant surgery. So cardiothoracic surgery is predominant surgery that involves the heart and the lungs. Neurosurgery involves surgery that pertains to the brain and also the spinal cord. General surgery. In the olden days, general surgery almost pertained to the majority of specialities, out with the others that I've labelled. It encompassed everything, including breast surgery, endocrine surgery, abdominal surgery, vascular surgery, everything. But of course, as time went on and as research progressed, it became not possible for one man to be able to do so many different operations. So in this day and age, a general surgeon is predominantly defined as a gastrointestinal surgeon, and they are subdivided into an upper GI surgeon, a lower GI surgeon. The upper GI surgeon would include things like esophagus, liver, pancreatic surgery, etc. And the lower GI surgeon, effectively, colorectal surgery. Breast surgery has become its own speciality to an extent, but there's some overlap with other things too. Now, oral maxillofacial surgery, that's a very interesting one. It's about predominantly, as you would see, in the face and the head, but people who specialize in this are usually dual qualified. So they've done a full 5-year dentistry degree, and then they apply to do the accelerated medical degree of 4 years, because they've already done a lot of basic science teaching in their dentistry degree. So they bypass that and go straight into clinical training. So they do a very condensed 1-year preclinical in the medical degree. So oral maxillofacial surgery, these are dual qualified, so like 9 years at university, which is a long time. But this is a very niche specialist field. So oral maxillofacial surgery. Otolaryngology. Now, ENT surgery, this focuses on the ear, nose, and throat. This again is a very interesting and offers a good variety. Pediatric surgery, anything from a newborn baby up to and including 16 years old. Generally, sometimes it's a bit varied depending on hospital, 16 to 18. But pediatric surgery is basically the general surgery equivalent, but for people of a pediatric age. Plastic surgery, or I guess more specifically, plastic and reconstructive surgery. So plastic surgeons, the skin is the largest organ in the body, and plastic surgeons will deal with things like burns, specialized burns unit. They will deal with aesthetic surgery, and they also have an overlap with some units do hand surgery alongside orthopedics, which I'll go into more detail. And they're also involved in trauma surgery as well. So plastic surgery also offers a very wide variety of elements within their day-to-day practice too. Urology, which previously was under the umbrella of general surgery, but has become over the years its own speciality out with, focuses on the kidney, the ureters, and the bladder, and other aspects of the urological system. So the people who've got required nephrectomies or interventions of the bladder, these come for urology. And vascular surgery, which also in generations ago came under the umbrella of a general surgeon, now again its own speciality. Vascular surgeons deal with arteries and veins in the legs, the arms, and also the abdominal aorta. So people who have peripheral vascular disease, or people who have varicose veins, and a lot of other things of that nature come under the remit of vascular surgery. And then there is, of course, my specialty of trauma and orthopedic surgery. At the top, you've got a patient who's got arthritis in their knee, who had a knee replacement, and at the bottom, there's an X-ray of a patient who's got a fractured tibia and fibula, their shin bone, of their lower leg, and then the X-ray next to it showing an intramedullary nail surgery fixation of the fracture. So I'll go into a bit more detail about what orthopedics is. Now, orthopedics, it takes its origins from the Greek translation of orthos and pedia. So translated, orthopedic actually means straight child. And the purpose of that is a lot of what we deal with are deformities of bones and joints, and a lot of interventions are focused to try to ameliorate and effectively straighten out or improve the deformities which lead to disabilities. That is the tree of André, developed by Nicolas André in Paris in 1741, which basically is the emblem of British orthopedics in this day and age. Now, orthopedic surgery is surgery that's focused on the musculoskeletal system, being bones and joints in the arms, the legs, and in the spine. There's obviously bones and joints in other parts of, for example, you have the mandibone, temporomandibular joint, that comes under the auspices of the maxillofacial surgeons. So orthopedics is bones and joints in the arms, legs, and in the spine. Now, all the surgical specialities that I shared with you earlier have its surgical counterpart and it's got its medical counterpart, because there is some overlap between the two. Orthopedic surgery is the surgical intervention of treating patients with bones and joint pathology. Rheumatology is our physician counterpart. So if I give you, for example, rheumatoid arthritis, these are patients who have an inflammatory arthropathy. The medical treatment given by rheumatologists has very much changed dramatically and very successfully the management of rheumatoid arthritis. The intervention of rheumatologists and physicians in general are more through medical therapy, such as drugs, interventions, and such like. So most specialties have its medical counterpart. A cardiac surgeon's counterpart is a cardiologist who's a physician. If we say that general surgeons predominantly focus on the gastrointestinal tract, then their physician counterpart is a gastroenterologist. So there's a commonality between our mirror physician speciality and referrals between the two. And there are occasions where you require joint input and efforts between surgeon and physician, depending on what the patient's ailment and disease is. Now, trauma and orthopedic surgery being divided into two halves. Trauma is the physical, if someone's been in a car accident or had physical trauma, which has resulted in a fracture. For example, this X-ray here, this is someone who's got a fractured femur or a fractured thigh bone, and they've been treated with, again, an intramedullary nail to fix the fracture, reduce it, and thereafter the patient's rehabilitated back to health. So the trauma aspect is the acute injury that people present with. The orthopedic aspect is more elective, it's more on the routine side. This X-ray of a knee joint shows on the left patient who's got advanced osteoarthritis of the knee, and patients who've got knee pain will go to their GP, describe their symptoms of pain. The general practitioner will treat them with first-line interventions such as analgesics, orthotics, crutches, etc., to help them as first-line measures. But people who continue to have pain despite non-operative treatment get referred to the elective routine outpatient clinic for consideration for a total knee replacement, for example, in this case, as you can see. So trauma is the acute element that comes through the accident and emergency department, or the ER, the emergency room department. The orthopedic surgery is on the elective side, and just about all surgical specialities mirror this. There will be some chronic diseases and vascular surgery that come through the elective clinic. There'll be some acute conditions come acutely, such as a leaking abdominal aortic aneurysm for the vascular surgeon, and so on. The same for general surgeon. Someone who has acute appendicitis will come in with acute abdominal pain requiring urgent surgery for their abdomen, and others may require, such as a gallbladder, could have a semi-elective or an elective cholecystectomy removal gallbladder. So as a general rule, most surgical specialities have their on-call acute work and their routine elective work that's referred through the GP. Now, orthopedics is a very interesting specialty. Pediatric surgery in itself is mostly focused on abdominal surgery amongst other elements. But in orthopedics, we've got a very interesting specialty which provides amazing variety, because we literally treat people from their pediatric age group right through to the geriatric age group. On the left, you've got a child who's had a broken forearm. We call this a green stick fracture, and we treat them accordingly with quite often manipulation, applying a plaster Paris cast. And the X-ray on the right is that of a fractured hip, in patients in their later years of life who have osteoporosis or weak bones can have falls and sustain osteoporotic fractures, such as fractured hip joints, or fractured wrists, fractured shoulder, etc. So we manage everything from pediatric, geriatric, young adults, and everything in between. And the variety is a spice of life. It makes our work very, very interesting and very gratifying to help people. Now, even though my specialty of trauma and orthopedics predominantly focuses on the aspects that we discussed, there are, as well as overlap between our physician counterparts in rheumatology, there's also overlap with other surgical specialities. For example, we discussed earlier plastic surgeons who predominantly treat burns, reconstructive aesthetic surgery. They do also have strong input into hand surgery. So to be a hand surgeon, you can do so either through the route of a plastic surgeon or through the route of an orthopedic surgical training. Similarly, orthopedic surgeons also involve, as well as the upper limb, the arms, and the lower limb, the legs, we also operate on the spine, be it spine fractures acutely or chronic presentations of, let's say, sciatica and disc herniations. So neurosurgeons also operate on the spine as well. So neurosurgeons will operate on the brain and the spine, and orthopedics will operate on the spine as well, so there's overlap. And vascular surgery I've also included in there because quite often patients will present with generic leg pain. And it's after clinical assessment and evaluation do you decide whether the leg pain is due from a problem with bones and joints, or whether the pain in the legs due to, say, peripheral vascular disease, where it's more relevant to vascular surgery. So there's overlap within this, within fields too. Right, now then, what happens after you graduate your university? You then become do a 2-year foundation program. Now, the traditional makeup of most foundation programs includes 12 months as a FY1 doctor, a foundation year 1, and 12 months as a foundation year 2 doctor. And within that, they break that 12 months up into 3 blocks of 4 months each. For example, in your F1 year, you could have 4 months of psychiatry, 4 months of gastroenterology, and 4 months of cardiology. In your FY2 year, you could have 4 months of general practice, 4 months of trauma and orthopedics, and 4 months of accident and emergency. So you get to rotate around a good breadth of specialities that helps further form the platform of your later training. Now, some people graduate medical school and they know exactly what specialty they want to do. Others still have yet to decide what specialty they wish to choose. And this variety of surgical specialities allows them the opportunity to gain that further insight and help make better informed decisions as to what route they wish to take thereafter. So there is the other option, which I'll bring to your attention too. And it's from my background, clinical academia. As well as applying for a standard 2-year foundation program, which is what the overwhelming majority of medical student graduates do, you also have the opportunity or the option to apply for what used to be called academic foundation program. It's now called specialized foundation program. Now, the difference here is you still do FY1, FY2 for 2 years, but they replace 1 full block of 4 months in your F1 year to do full-time research, and they replace 1 of your 4-month blocks in F2 to do full-time research. Now, you still end up doing 4 months of psychiatry in your F1, 4 months of gastroenterology in your second block, but your last 4 months, rather than doing 4 months of cardiology, they come and do 4 months of research with me. And then in your F2 year, they go back to clinical work and do 4 months of trauma and orthopedic surgery, 4 months of GP, but their last 4 months, they'll come back and do full 4 months of research with me. Now, this is a very, very competitive field to get into. And one of the advantages of, say, Newcastle University is when they graduate with a medical of Masters of Research degree under their belt, when they come to apply for these very competitive academic foundation programs, they're in an excellent position and a very strong CV for their application for this. So that's just another option for when people graduate, if they're academically inclined. Now, at the end of your F2, you then come with choices of you then need to decide which direction do you wish to take your career, or perhaps at that junction, your training further. And you have a variety. The beauty of medicine, it is very varied. So you can choose general practice, medicine, psychiatry, radiology, many other things. This is obviously not all encompassing. However, for focusing on the theme of this talk, if you've decided you wish to pursue a career in surgery, then you're going to apply for what we call a core surgical training program, which again is 2 years. You spend as your CT1, and there's some slight variations of this, but still in the same ballpark, because some core surgical training programs change. And you'll appreciate that by the time you guys graduate medical school, the postgraduate training changes from time to time. So there might be certain fine details of this that may be slightly changed, but overall the theme remains the same. So in your CT1 or your core trainee 1 year, you'll go around 4 surgical specialities. So unlike your foundation program, well, there'll be a mixture of surgical and medical. If you've decided you want to do surgery, it'll be surgery and only surgery moving forward thereafter. So you could do 4 months of vascular surgery, 4 months of urology, and 4 months of general surgery as CT1. And as CT2, depending on what the theme of the CST program you choose, it could be 6 months trauma and orthopedics and 6 months plastic surgery, or things of that nature. So this is the natural continuation following foundation program. Now, during that time, you spend 5 years of doing a lot of exams. You're not finished with exams yet, because within that core surgical training 2 years, you then have to sit, in order to progress to the next stage, your MRCS exam, Member of the Royal College of Surgeons exam. Now, it's an exam into Part A, Part B. There is a written component, which includes MCQs and long answer questions, as well as a clinical component where you're assessed as you examine patients and ask other clinical questions. So it's in 2 parts. And in the UK and Ireland, there are 4 recognised royal colleges to which people who wish to sit their MRCS exam apply to. They are the Royal College of Surgeons of England, based in London. It's the Royal College of Surgeons of Edinburgh, based in Edinburgh, of course. There's the Royal College of in Ireland, and the Royal College of Surgeons in Ireland is based in Dublin. And then there's the Royal College of Physicians and Surgeons of Glasgow, and that's based in Glasgow as well. So during your core training year, you apply to do your MRCS exam in one of these 4 accredited royal colleges, and you do so revising for the exam whilst you still continue doing your day job and your clinical training. So it's a lot of hard work. One interesting fact: you spend 5 or 6 years studying in medical school, and eventually when you graduate, you become doctor. And that's fantastic, and everyone's so happy and proud of you, and you feel like you made a massive achievement, and of course you have. And then you spend your foundation doctor years also being a doctor, and the early part of your core training years being a doctor. However, once you pass your MRCS, you revert back to being, in my case, a Mr. So I went from being Dr. Al-Dadah after I graduated in my early years of training. And once I passed my MRCS exam, I became Mr. Al-Dadah. Now, the UK is unique in this. The UK, to my understanding, is the only or one of the few countries on planet Earth where this happens, because everywhere else, even after you pass your postgraduate surgical exams, you remain a doctor, such as in America, Canada, and Europe. Now, why does UK call you a Mister? It's to do with historic, going back to the 17th century, 16th century. People in those days were, the physicians were doctors, but the people who did surgical procedures, such as debriding infections, amputations, or all sorts of surgical interventions, these were predominantly done by people who were not actually qualified doctors, as the physicians of those era were. And funnily enough, barbers who cut hair, because of their skill with a razor and their aptitude with sharp objects, I guess, and of course, they were not entitled to be called doctors, despite the fact that they performed invasive surgical procedures. And so in those, it takes its historic traditions from those days. And if you walk past a barber shop, and a true old-fashioned barber shop, you'll see on the outside of it that it's got its characteristic red and white post. Now, the red represents blood and white represents a bandage. So this stems from its ancient era of where barbers used to actually perform surgical procedures. So why am I called Mr. Al-Dadah rather than Dr. Al-Dadah? It's because of the historic traditions within the UK. Now, back to your training. You've passed your, you've been successful in gaining your 2 years of core surgical training. You've progressed in your basic surgical training. You've passed your MRCS exam. You're now Mr., Miss, Mrs., as is appropriate. Now, you then apply for ST training, specialty training in your chosen field. So, for example, if you decided to pursue a career in trauma and orthopedic surgery, now that is 6 years of training focused only on trauma and orthopedic surgery. And you're now no longer, whereas previously we were allowed to call them junior doctors, you then progress to the middle tier, because the tier system in the medical profession goes from the consultant, the registrar, and then the junior doctor, as it was previously, now known as resident doctor. So you're now stepping up into the middle tier of the profession, and that comes obviously with more responsibility, but you're exposed to more training focused on all aspects of that specialty. So we said that orthopedics involves the arms and the legs, so everyone will rotate and do 6 months of spine surgery, working with a consultant spine surgeon, 6 months with a knee surgeon, 6 months with a hip surgeon, 6 months with a shoulder surgeon, and so on. So they get the breadth of the generality of trauma and orthopedics. Now, and that usually takes 6 years. Most programs are 6 years, and most surgical specialties are 6 years, but there'll be some slight variation, depending what specialty you wish to apply for. Now, within your training as an ST trainee, or indeed there's potentially the option to do it at any time point in your postgraduate career, there's the option of taking what we call an out-of-program experience, that depending on whether or not it whetted your appetite of doing research in your younger years, you have the option of doing either an MD or a PhD. An MD is a doctor of medicine, a PhD is a doctor of philosophy. But the pecking order, if you wish, you've got people who do a bachelor's degree, the one above that is a master's degree, and the one above that is a doctorate degree. So if people who wish to have a substantive period of time doing a lot of research, then they can opt to take time out of that training program to do a period of time. It could be 1, 2, 3 years of focused research. And once they've completed that and have passed their doctorate theses, they can come back to finish off the remainder of their training. I did my registrar training on the Cambridge Trauma and Orthopedic program, and I had the privilege of rotating around Cambridge and all of East Anglia. It was an amazing, very good training program. And during that time, I also completed my doctorate thesis, my MD thesis, and it was on the topic of my area of specialist expertise on reconstructive knee surgery. I had two excellent professors who mentored me and taught me a lot about the world of research, quantitative research, data analysis, data collection, and from which I met with a lot of success. And I managed to generate a lot of publications in peer-reviewed, international peer-reviewed journals. And I was invited to deliver presentations on the research that we did in national and international conferences. And indeed, I was fortunate enough to win some prizes. So I was fortunate enough to meet with a lot of success in my my doctorate thesis fellowship that I did, and that obviously encouraged me to continue in my academic journey, even as a consultant, where I help other doctors in training and medical students gain their own research degrees and supervise them doing research. So research is very valuable. It helps progress the profession. My particular research looked into proprioception, which we evaluated through an electronic platform, looking at patients before and after sports knee reconstructive surgery. We also looked at patient-reported outcome measures and did mathematical modeling and developed formulae where we could predict the results of one clinical outcome from another. And we also developed specialized techniques of magnetic resonance imaging, which further improved the diagnostic accuracy of anterocruciate ligament ruptures and meniscal tears. So good grounding in research allows for people to be at the forefront of developing new technologies, new information, and sharing that with the rest of the world effectively. So once you think you've had enough of book work, no, because you also have to do, prior to finishing a training, another exam, because you haven't had enough exams yet. So let's do an FRCS trauma and orthopedic exam. Now, our MRCS was a member of the Royal College of Surgeons. Your FRCS is a fellow of the Royal College of Surgeons. Now, the TRA and Orth is trauma and orthopedic special spine. If it was cardiothoracic surgery, it would be FRCS cardiothoracic. If it was FRCS general surgery, and so on. So you then have to do another exam, and that's also split into two parts, a part one and a part two, to make sure. And people usually sit this exam in the latter years of their training, say year 5, year 6, etc. So now that you've had all that training, all that expertise, and you've passed exams, you are then eligible to be awarded by the deanery of the region that you have trained in the certificate of completion of training, and then your name goes on to the specialist register on the General Medical Council. Now, you think, great, does that mean finished my training? No, it's not, because after you finish your training and gain all your exams, and if you chose to do your theses as well, you then go and do a fellowship, a clinical subspecialist fellowship for 1 or 2 years, because in this day and age, a lot of us subspecialize, and therefore for your consultant career, you're going to offer further specialist techniques. The ST training is there to give you broad generality of trauma orthopedics. Your fellowship training is there to teach you further in-depth specialist techniques in the subspecialist area that you have chosen. Now, popular destinations for trainees in the UK to do their fellowship training, a lot of people stay within the UK. Some people stay within the same region. So if someone who trained in the northeast of England on the Newcastle rotation may choose to pick another centre in the northeast to train with a certain consultant who does very specialist surgery, or they can choose to go to another region in the UK. So they might choose to go down to Bristol, Southampton, somewhere in London to work with a consultant who offers specialist fellowship training in a particular niche field. Others may choose to go abroad, and popular destinations include Australia, New Zealand, and Canada, and also to some extent the USA. Now, predominantly Australia, New Zealand, Canada. Why? Because they're English speaking, and the trainees gain a lot from going to see another health system in a different country. The only reason I hesitate slightly with the USA is because unless you pass their USMLEs, there's a limit as to how much there is zero ability to actually patient contact and operating if you haven't passed yet another exam, USMLE, and that slightly deters people going to the USA. But for Australia, New Zealand, Canada, they recognise the British training, so you can go there and do the surgery and patient contact like you would do here. So they gain a lot of experience, a lot of specialized training. And once you've finished your fellowship training, then that's right, you eventually get the name badge that I wear every day saying consultant surgeon. And that's after a very long path. Now, that, of course, is if you meet all your milestones first time round from the date you graduate of 2 years foundation, 2 years course of training, and 6 years. So that's effectively 10 years. I can assure you, more often than not, usually the average is about 12 to 14 years from the day you graduate university to the day you become a consultant, when you factor in fellowship training as well. So although it's a very long training path, you have a colossal amount of training, expertise, and knowledge, as one would expect when they come to see a surgeon, consultant surgeon in the hospital setting. Now, within orthopedics, as I mentioned, there's an increasing vogue of subspecialization, and people then go and do their fellowship. I specialize in knee surgery. I've got colleagues who specialize in foot and ankle surgery, and so on. And that way, the advantage that confers is that when you come up to see a knee specialist, he does a high volume of specialist knee surgery, and people who do a high volume of certain operations, their outcomes are very good. So subspecialization is very much the order of the day, and that's the case in most of the other surgical specialties we've discussed in this day and age. Now, what's your general day-to-day work life like as a surgeon? Today, I've been doing outpatient clinic all day. So patients are referred from the general practitioner who've had knee pain that continues to be particularly painful despite the analgesia painkillers that they've had in the community. So they come to then get consulted by me to see their suitability for having reconstructive knee surgery. Once we've decided, they go on my waiting list, and then I have the great privilege of working in theatre with a fantastic team around me. I was in theatre all day yesterday doing knee replacements and ligament reconstructions and such like. So the operating theatre, where I work with my anaesthetic colleagues, the theatre staff, in the teamwork environment, we provide amazing care with other nursing staff. And then once the operation is done, of course, they are looked after by, again, another fantastic team of nurses, physiotherapists, occupational therapists, and a multidisciplinary team to get the patient better and mobilized, rehabilitated. So ward rounds, clinics, theatres, these are all part and parcel of the working life of a surgeon. What's the future of surgery? So the people I'm talking to just now, I'll be long retired, and you guys will be looking after us. So by the time you guys become consultants, there's a lot of research that I see being submitted to my journal that I edit on robotics, artificial intelligence, and digital technologies. And you guys will be, I'm sure, far, far more computer literate than I am. It's a lot of these things will be second nature to you. So your background and your interest in technology as it is now, there is certainly opportunities for this to be further incorporated in all fields of medicine and surgery. And I certainly see that being driven by more and more research, that digital and robotic technologies will further enhance what we currently do today. Now, things that you guys can do even from your stage where you are. So where can I go and get some more information? If you log into the Royal College of Surgeons website, so I've taken this from the Royal College of Surgeons of England, there's plenty of information on career structure, career support. There are avenues for medical students to get more involved and even sign up and be part of the Royal College of Surgeons, and they give you insights, reading resources. Now, one thing I would like to make a point of saying about women in surgery, traditionally 50 years ago, possibly even 15 years ago, surgery was a very, very male-predominated arena, especially trauma and orthopedic surgery. The females were very, very few and far between. In this day and age, I think, I can't remember the last statistic, something like 60%, sometimes even 70% in some medical schools are females as medical students. So naturally, as the proportion of women studying medicine has substantially increased over the years, we would love to encourage more females to consider a career in surgery too. Now, there is a great degree of flexibility in the workplace. We accommodate people who wish to work less than full time. We accommodate people who've got their own personal needs to accommodate having their work-life balance. So there are opportunities where we can welcome lots of women into surgery, and I'm very, very fortunate to have some fantastic female consultant colleagues, and we've got fantastic female trainees as ST trainees who are excellent. They provide a very welcome input into progressing our profession, and there are certainly very key influential female figures who champion and promote encouraging women to do surgery. So a lot of my research fellows as well have been females who've done research on trauma orthopedics with a view to progressing into orthopedics in their future career. So again, this is a resource on the Royal College of Surgeons website. It's very good. It gives you opportunities to network and get in contact with other like-minded people, and they'll be a valuable source of information. And this I would commend to all of you as well. This gives a very good application of careers and research, what's it entailing, postgraduate opportunities, and also undergraduate opportunities as well. And for the British Orthopaedic Association, my field in trauma orthopedics, we also have opportunities for medical students to get involved in signing up and getting further insights, attending conferences that we hold, our annual national conference, which has thousands of people turning up. So medical students can start to engage in surgical specialities of areas of their interest at an early stage, and that helps them network, that helps them gain more information, that encourages them to do research in the field. So there's lots of opportunities out there for people to get involved with surgical affiliated societies. Now, just some brief tips. I'm not going to encroach on at all on the admissions lectures that you guys will get, which will be fantastic. It will give you far better insights into the application process from where you are, but probably just some very broad principles I would share with you. Now, getting into medical school is not easy. You've seen the rigorous amount of exams and long journeys that you have. So academic grades are important. So study hard, get good grades. But that's only one part of being a doctor. You know, your academic grades is a reflection of your higher level of intelligence, so that you can assimilate all that training that you have to go through and all the exams that you have to go through as a postgraduate. However, at your stage, certainly I did when I was your age, work experience is important too. And if you get a variety of opportunities, either in hospital, whether it's physicians, surgeons, etc., I will also caveat that most hospitals, including my one, we generally don't allow people under the age of 16 to go into the operating theatre, but they can still go to clinic and ward rounds. I would encourage you, yourself and your family will be registered with a general practice. I also went to do work experience with my local general practitioner, and even allied health professionals. So when I was at school, I did my work experience placement in a pharmacy. I enjoyed it. It's allied health professional. I actually managed to get a summer job out of it as well, but that also was very health related. So when you come to write your personal statement in your UCAS, bring a lot of that out, because you want to. They'll be interested to know why you want to be a doctor. You may have your own personal reasons, but also the fact that you've had work experience shows that you've had that insight into what being a doctor entails, and that has not deterred you, only further made you more enthused to pursue that career. I've known some people who have done volunteering work and charity work, and that's excellent. That also shows a very empathetic nature that would be welcome in the medical profession. But do also remember, we also will be interested in you as a person, your personal achievements, your extracurricular activities. When I was at school, I played for the school football team, and as well as other football teams in my local vicinity. I thoroughly enjoyed that. Are there evidence or elements of teamwork that you've been involved in? Because you've seen that most of my lecture is involved about teamwork in all facets, at all grades. You might have some elements of creativity. Maybe you're a very gifted artist. Maybe there's some other unique elements that you can bring to the fore. If you've got good background in information technology, I've already showed how information technology is very much the future in our profession. You might also have other attributes. You have foreign languages or anything else. Try and bring that out as well in your personal statement, because it gives the reader of that application a good holistic impression of you as a person. And the interview, most universities, my understanding is, ask for an interview. So again, that they want to see again why you want to be a doctor, but they're also looking at you as if you were in my seat just now, if you were their doctor, how you come across. Because I will leave you with this very important thing. Your academic grades are important. All the time and effort you put is very important. But the most important attribute of a doctor is your communication skills. Patients come to a doctor to communicate to them their ailments and their concerns. Then the doctor will take that and communicate back to the patient at how best it can help them. So communication skills important between our colleagues. Communication skills is very, very important, and that will come across as well in your interview, and even writing your personal statement is a form of communication. So remember, that's not just for your application to university, not only for your undergraduate career, but your entire life as a postgraduate doctor. Communication skills is the most important attribute of a doctor. I'd like to thank you very much for your kind attention. And I'd also like to wish you all the very best of luck in your application, and indeed the very best of luck in your undergraduate and indeed postgraduate career. So thank you for your time and attention, and I'll hand back over to Ashley and Brandon, and I welcome question time and happy to answer any questions.